to welcome Dr. Judy Luu, who is a women's heart health cardiologist. She's also an expert in cardiac MRI, and she's currently the director of research at the Couture Cardiac MRI program at the McGill University Health Center. So she completed an MD PhD with a focus on using cardiac MRI in patients with ischemic heart disease. And so this was done under the leadership of some world experts. One of them is Dr. Matthias Frederick. And after she finished her adult cardiology residency, Dr. Luu pursued subspecialty training, this time at the Women's Heart Disease at Cedars Sinai Medical Center in Los Angeles, with another world-renowned expert, in this case, Dr. Noel Derry-Mays. So Dr. Luu's interests include using non-invasive imaging to better diagnose women with coronary vasomotor dysfunction. And so she's very passionate with her advocacy, which includes raising awareness for women's heart health in underserved minority populations. And so Dr. Luu is currently the executive co-chair of the Advocacy Working Group for the National Canadian Women's Heart Health Alliance. So it is a pleasure to welcome her, and she's going to be talking about sex and gender differences in ischemic heart disease. Dr. Luu.
Thank you so much. As a Dr. Mwal?
Yeah.
Thank you so much for the introduction. Yeah. So it's an honor to be able to present to you your whole entire team today, and thank you for Jeanette for reaching out. Today, I'd like to talk about exactly that. Sorry, let me get my slides going. Oops. Just sex and gender differences in overall cardiovascular disease, and specifically coronary artery disease. I do know that the majority of you guys are in the experimental surgery, so this may or may not be relevant, but feel free to reach out to me. I think it's important, no matter what area of research that you will engage in your future career paths, that you be aware of these sex and gender differences. And so today I'd like to just touch base on some of them for you. It's a little bit of not so much didactic, but feel free to raise your hand or enter in the chat questions anytime you have any questions, and I don't feel irritated or disrespectful if you need to interrupt me. I think it's important that you get the most out of this presentation or this learning as you can. And so I have no disclosures for this presentation. So to begin, I like with a scenario. And so in more layman terms, essentially it's a 50-year-old female who presents to her doctor's office for chest pain that has been ongoing for the last year. Sometimes it can occur several months, sometimes it doesn't happen at all. She describes this pain as sharp in quality. It's tight, it's radiating to her left neck. And sometimes she can also get numbness or tingling in the left side of her face. They mostly occur in the evening. Her past medical history: she has thyroid disease, high cholesterol, and high blood pressure. And the medications she's on include thyroid medications and blood pressure pills. These are just some routine information that the family doctor provides. And so her lab work, all it basically is her lab work and her vitals. So vitals are her heart rate, blood pressure, her oxygenation, her respiratory rate, and her physical exam are essentially unremarkable. And so I like to poll the audience, if this is you, or if you have any woman in your life, your mother, your sister, your aunt, your grandmother, and she presents to the hospital, to the family doctor, what do you think they would do next? And so these are some testing that they could order. They could order essentially exercise stress testing with either treadmill test, modalities we call echocardiography or nuclear exams. They can also order coronary angiogram, which is an invasive procedure that looks at the arteries of the heart. They can order a cardiac stress MRI or a PET nuclear scan, or they can actually not order anything and send her home with nitroglycerin and follow up with her. So for those, and keep that in your back pocket, and you decide if this was you or your family member, what you would want them to do. So in fact, she went on for multiple months and years, and she did get a lot of testing done. Essentially, all of these modalities, the nuclear SPECT, the ultrasound, which is the echo, the angiography performed by the CAT scan, and even her treadmill test doesn't show any significant abnormalities. And she was told that everything was normal. Sorry. And so at this point, what do you think they should do next, or you should do next? Do you just tell her that this is likely a non-cardiac chest pain, and you reassure and you recommend that she follow up back with her family doctor? Would you urge them to do additional alternative cardiac investigations? Would you also tell her this is not cardiac, but why don't I refer you to other internal medicine specialists that you may know? Or would you try to add additional anti-anginals, which in this case would be something like a beta blocker? You may have heard it was called metoprolol, and then follow up with her in a few months. And then finally, you can also say, I'm really not sure what to do next. Yeah, so please keep up with it in your mind, and we'll return back to the case later. So the objectives for my talk today for you are twofold. I'd like to help you understand the sex and gender differences in the presentation, diagnosis, and management of patients who present with coronary artery disease. And then finally, I also like to review the non-atherosclerotic causes of ischemia and infarction, which is another word for heart attack, in patients who present with that. If there's not enough time for the second objective, that's okay. We could reserve it for another time, because I do believe I have about up until 1:45 and then room for questions after. So to begin, I believe it's important that we emphasize that cardiovascular disease is on the rise, and this is especially concerning for women. You can see from this graph, which is vital statistics published from the WHO mortality database, and they've actually shown a significant slowdown in the rate of decline of cardiovascular disease in many of these high-income countries here. And importantly, you can see here, this is the rate of decline, but as of 2015, you can see here that alarmingly, the mortality rates have actually increased in both the United States and in Canada for females specifically. And that's quite alarming, because we are one of the leading countries in terms of medical care and health resources. So there are multiple disparities for women in ischemic heart disease. You can see from a diagnostic perspective that less than 1 in 10 women who have chest pain, so angina, and who have abnormal stress tests go on to receive any medications or referral for additional diagnostic angiography to rule out obstructive disease. You can see from the acute coronary syndrome, or ACS, so when someone comes in with elevated blood markers, cardiac blood markers, who have strong suspicion for a heart attack, that women are less likely to get revascularized, which means they're less likely to get that artery fixed when they're having a heart attack. They're also less likely to be referred for surgery for revascularization when they're having a heart attack. And that overall, women who undergo coronary artery bypass grafting, or CABG, are less likely to receive arterial grafts, which are actually the stronger of the two grafts between arterial and venous grafts. And then overall, again, women are less likely to get referred for important diagnostic testing to rule out obstructive disease. And from the pharmacotherapy or the medication perspective, women are less likely to achieve what we call guideline-directed pharmacotherapy. And so therefore, as a result, are less likely to achieve those prevention targets. So in cardiology, we have very firm standards of what a person's individual cholesterol levels, blood pressure targets, and all of that should be. And the women are overall, if they're not receiving the right medications, they're not being counseled appropriately. And so there are large disparities for women with ischemic heart disease, and this disproportionately then results in a higher morbidity and mortality for women overall. And we're seeing that as a trend globally. And so when I speak about ischemic heart disease, for decades, the primary focus when managing someone who comes in with chest pain has been to verify whether or not they have major blockages of their major arteries. And in recent years, there's really been a new paradigm that has emerged for ischemic heart disease. You can see here from this figure that INOCA, or ischemia with no obstructive coronary artery disease, is really a proposed term that conveys the importance of the stable coronary syndromes beyond obstructive coronary artery disease. And you can see that INOCA aligns with its sibling term MANOCA, so myocardial infarction with no obstructive coronary artery disease, and that's heart attack with no major blockages. It's really its own diverse syndrome with very distinct underlying causes. Today, I'll focus first on INOCA, and then later on, if there's time, we can talk more about MANOCA too. And so what is INOCA? And so in its most simplest term, INOCA is a condition where patients present with symptoms and signs of ischemia, so reduced blood flow and oxygenation to the heart, but then they're found to not have any major blockages in their major coronary artery disease, their major epicardial arteries. And so in studies that have been performed in the past, non-obstructive coronary arteries is very common. It can be found in up to 2/3 of women and 1/3 of men who undergo coronary angiography for their chest pain. You can see from this graph, from this large Danish cohort of over 11,000 patients, that the proportion of those with no obstructive coronary artery disease is actually increasing in both women and men. So it's actually more common than we think. And using the Women's Ischemia Syndrome Evaluation, so it's a large study done for over 2 decades now called the WISE study, they've shown that patients with INOCA have a high burden of angina. And so 30%, so about 1/3 of these women who have angina actually have persistent symptoms at 1 year. And these anginal symptoms or cardiac symptoms can be very broad. They can be things like heartburn, abdominal pain, overall generalized weakness, shoulder pain, back pain. And so we now are trying to be more aware that women who present with heart symptoms may or may not have chest pressure, and it could be very broad. It's also important to note that there's an ethnicity difference. So Black women, they tend to report more stomach-related pain rather than white women who report more chest symptoms. And so you can see here why often heart conditions and heart attacks can be missed in women, especially missed in women of minority backgrounds, because their symptoms are not as commonly thought of, which is just chest pressure. And the prognosis for people who have ischemia with no obstructive coronary, so INOCA, is actually not benign. So you can see here that women with INOCA have up to 6 times increased risk of having a major adverse cardiovascular event. So they're 6 times increased risk for having things like heart attack, stroke, heart failure at 5 years. And they're also at increased risk for repeat hospitalizations for repeat investigations due to the recurring chest pain that's not being optimized in the community. And I want to reiterate again that the main key takeaway point is that INOCA is not benign. It disproportionately affects more women than men, and that it's also being poorly under-recognized and undertreated. You can see here from this graph, these are on the bottom, these are risk scores that we use routinely in our cardiology practice to risk stratify individuals for future events of heart attack and stroke at 5 and 10 years. And you can see that women with INOCA are routinely the risk score is underestimated. And so in fact, these women with INOCA should be considered higher risk, and that these primary tools for risk stratification are really should not be applied because they often underestimate the risk of women who have INOCA. And this is also a key takeaway slide that I want to spend a bit more time on. And so it's the risk factors for ischemic heart disease are different in women compared to men. You can see that, you know, the traditional risk factors like high blood pressure, high cholesterol, smoking, et cetera, while they're still there, they actually differentially impact the woman more than they do the male. So for a woman who has diabetes, she's 45 times more likely to have ischemic heart disease compared to a male. Same thing with hypertension. There's now more and more studies showing that the blood pressure targets for a man should be different from a woman. In fact, it should be 10 millimeters of mercury less than that of a man. And so women are often, you know, with blood pressures, let's say at 130/80, are told that they're fine, but in fact, she is hypertensive and she's beyond stage 1 hypertensive and she's not being optimized. We also know that there are emerging risk factors for ischemic heart disease that are female specific, we call them. And so there are things related to the reproductive history of a woman, you know, complications, you know, adverse pregnancy outcomes, complications during pregnancy are also now known to be a risk factor for, you know, future risk of diabetes, high blood pressures, and heart disease down the road. So if a woman has had preeclampsia, which is high blood pressure during a pregnancy, she's often told that once the baby is delivered, you're fine, but that's not the case. We know that about 10 years out of that average pregnancy outcome, she has increased risk for having her first heart attack, stroke, and then down the road developing heart failure. So we're now more aware that the reproductive system and its abnormalities is also important. Women who have early menopause, so the average age of menopause is before the age of 50, and any woman who's had menopause or any female who's had menopause earlier than the age of 50 is also at increased risk for heart disease and accelerated aging in her heart, and we know that. And then other risk factors like autoimmune disease, depression, anxiety also differentially impact the women more than they do the male. So we need to be thinking of women at all stages of her lifespan. And so when you are doing your studies, whether or not they're in animal models or in human models, you have to really take into focus the sex differences around the reproduction of that animal, or that, in our case, in humans. And so this figure really nicely outlines other risk factors. We call them female-specific risk enhancers. Risk enhancers because they're not factors. You know, the fact that you've had a pregnancy outcome, adverse pregnancy outcome, means that you can't change that risk factor like you can diabetes or high cholesterol, lowering that. But it actually means it's a risk enhancer for having a higher chances of getting heart disease down the road. And so some things to keep in mind as you conduct your studies. And so when we think of myocardial ischemia, it's now thought of as much more broadly, and multiple mechanisms can contribute to myocardial ischemia beyond just major blockages of your coronary arteries. And these are things like platelets and clotting factors, systemic inflammation, so autoimmune disease, overall just metabolic abnormalities, diabetes and hypertension, myocardial bridging, which are anatomical congenital malformations of the coronary arteries. And then these are the two causes that or mechanisms I will focus on more today, and they're specifically coronary microvascular dysfunction or vascular coronary vasospasm. And then together, these are called coronary vasomotor dysfunction. And so coronary vasomotor dysfunction is actually very common, especially in the INOCA population. So people who present with symptoms of chest pain and abnormalities on their stress tests, who have normal coronaries, actually often have coronary vasomotor dysfunction. And specifically, they have microvascular angina, which is when you have chest pain in the absence of major blockages due to diseases of your small blood vessels, or vasospastic angina, which is when the blood vessels kind of squeeze in on themselves, creating the sensation of angina. And so you can see that it's actually very common. Coronary vasomotor dysfunction can be seen or can be found in up to 60 to 90% of patients who present with INOCA. And as depicted in this figure here, you can see that coronary microvascular dysfunction and vasospastic angina, while they're distinct conditions. They can actually cause ischemia in patients with non-obstructive disease, as well as those who have obstructive or major blockages, and that these phenotypes can actually overlap. So oftentimes it can be quite hard to diagnose which of these entities they have, and this is probably what contributes to ongoing confusion in the real world scenario as well. So let's now shift gear a little bit to the pathophysiology of the macro microcirculation. You can see here shown to the right is the extensive coronary arterial system of the heart. It's a vast network of vessels, segments of varying sizes with very distinct functions. You can see you have the endothelium forming the intima, and then you also have the media that comprises of the vascular smooth muscle cells, and all of these components interact with one another to allow dilation and vasoconstriction of your arterial bed. The coronary microvasculature or circulation, actually, you can see here from this really nice image here, makes up the majority of the blood volume and the resistance in the heart. So over about 75–80% of the blood volume resistance is actually controlled by these microcirculation. And the microcirculation is responsible for this dynamic regulation of blood flow through the control of hormone and sympathetic tone. And so there's a number of structural changes or microvascular remodeling that has been associated with coronary microvascular dysfunction. And they can include things like having diffuse atherosclerotic disease. So these aren't major blockages, but they're just diffuse disease that you can't quite see on the angiogram and testing that we do. You can also have abnormal thickening of your smooth muscle cells, and therefore adverse like abnormal interaction between hormones. And then finally, you can also have adverse changes in the capillary integrity of these beds, so they can, which then leads to capillary obstruction. And microvascular dysfunction can also result from a variable combination of impaired vasodilation. So it's not just structural, it can also have what they're functional, functional abnormalities. So impaired vasodilation or increased vasoconstriction. So you can have impaired vasodilation that's due to endothelial dependent. So that's related to, adenosine and catecholamine release, or it could be endothelial dependent, which is due to flow mediation, acetylcholine, and other neurotransmitter, other neurohormones. And then for increased vasoconstriction, you can also, that's oftentimes due to various stimuli like increased endothelin-1, acetylcholine, catecholamines, and so there's very interconnected. Some of you may be doing research in the lung, and the endothelin-1 plays a huge role in the development of pulmonary hypertension. So the increased vasoconstriction both in the cardiac bed and the pulmonary bed are exquisitely connected, and so we often see derangements from that aspect. And when I speak about coronary artery vasospasm, we know that the pathogenesis of vasospasm is actually quite complex. It's not fully elucidated yet, but it's actually thought to be due to an interplay between the endothelial dysfunction as well as what we call vascular smooth muscle cell hyperreactivity. And so what do I mean by that? It's so in a healthy endothelium, you can see here that acetylcholine stimulates the release of nitric oxide, which then mediates the vascular smooth muscle cell relaxation. And as a result, you get increased blood flow. But when you have high doses of acetylcholine, or when you have endothelial dysfunction, the acetylcholine actually can then directly stimulate the vascular smooth muscle cells to cause vasoconstriction, and then that can actually precipitate both epicardial and microvascular spasm. So you really see that it's a strong interplay of endothelial dysfunction and then vascular smooth muscle reactivity, hyperreactivity. So when I see a patient who has, INOCA or persistent symptoms despite being told that all their testing are normal, the goal from a diagnostic pathway approach is to determine if there is underlying coronary microvascular dysfunction or coronary vasomotor dysfunction. And so in my previous training that I did in Los Angeles, the approach that we took was to first rule out other secondary causes of coronary microvascular dysfunction. And this can be things like, cardiomyopathies, which are abnormalities in the heart muscle. It could be due to valvular heart disease, so things like stiff or leaky heart valves in the heart, and then high flow states like thyroid disease. After that, we actually choose a conservative empirical therapy approach because we don't want to be sending everybody for the invasive testing. And we will trial them on, risk factor modification and a trial of anti-anginals to improve their chest pain. But, in follow-up, if the patient does have persistent symptoms, that's when we proceed to additional quantitative testing to assess whether their coronary flow reserve is deranged, and it's mostly using, especially at McGill and that in LA where I did my training, cardiac MRI. It's important to note though, and that's why it's such a huge, women are often under-recognized and undertreated, is because that our routine negative stress test, like a treadmill test, an echo stress test, actually does not sufficiently rule out coronary microvascular dysfunction. So you can see from this table here that in patients who have INOCA, so they have chest pain with no major blockages, the traditional non-invasive tests like echo, like nuclear, have very limited diagnostic accuracy for detecting coronary vasomotor dysfunction. So the diagnostic accuracy you can see for all imaging modalities really only gives you like a 41% sensitivity and 57% specificity to diagnose coronary microvascular dysfunction. So overall, women, again, patients are often undertreated due to this very reason. So I'd like to take you back to the case study of that 50-year-old female who presents with persistent angina despite being told all her traditional testing were normal. She was finally taken for a cardiac MRI, stress cardiac MRI, where we give them a medication to mimic the effects of exercise on the heart. And then using a contrast agent, we see if there's any areas of reduced blood flow in the heart. These are images of cardiac MRI. You can see here that this, if you're not familiar, these are images of the heart. You can see this is a short axis slice of the heart, and this is the left side of the heart, the left ventricle and the right ventricle. This is what I call a 4-chamber view. So the left ventricle, the right ventricle, and the top two atriums. You can see that the heart is beating well. It has normal ventricular function and the size is normal. And then when we gave that contrast dye with that pharmacological stress agent, you can see that she has abnormal perfusion, which is shown by the areas of the dark rim in the subendocardial, in the inner layer of the heart muscle at peak stress. And so the no LGE means that there's no late gadolinium enhancement, which is there's no scar or fibrosis in her heart, which is a good marker. And that her myocardial perfusion reserve index, or that's a threshold to define microvascular dysfunction, the MPRI, it was less than 1.84 for her, meaning she does indeed have evidence of microvascular dysfunction. So in some cases, it's not always that straightforward where we, bring them to CMR and they're shown to have microvascular dysfunction. If it's not that straightforward and there's still clinical equipoise, the role of invasive coronary function testing really is pursued to better define that underlying etiology, because once we know what the underlying etiology is of a patient's chest pain, we're better able to treat them. So in this case, I'm going to talk a little bit more about that. This is when we refer them for invasive function testing to inject medications directly into the coronary arteries to see how they respond to the stimuli of adenosine and acetylcholine. And so just really quick, I don't think this is too pertinent to you, but in the cath lab, which is where they, using X-ray, they put a wire into the arteries of the patient, and we're able to essentially perform these function testing and see how the coronary artery responds, and we're able to assess for coronary vasorelaxation or vasoconstriction. You can see from this testing procedure, we're able to rule in or rule out if there's any major blockages of the epicardial arteries. We can tell if there's any myocardial bridging, which is abnormalities in the arterial artery itself, and then what we call increased nociception, which is just increased or hypersensitivity to sensation of pain, any sensation of pain. And then finally, when we do step 2 and step 3, we're just essentially injecting medications to see how the artery relaxes, so dilates, and how much it vasoconstricts. And that lets us know along the pathway if it's non-endothelial dependent or endothelial dependent, and importantly, if it's coronary vasospasm, depending on the different testing results we get. So definitely not for you to memorize, but just know that this is really with the second or third, fourth line investigations, if we're having ongoing suspicion that something is going on and we're just not appropriately treating the patient. And so I won't bombard you, but again, this is essentially kind of a schematic of what they do in the cath lab to show at different levels. We can see there's blockages in the main arteries and then down into the microcirculation. And this field is really advancing at a rapid pace. So the management for INOCA, or a patient who comes in with persistent symptoms and who have evidence of ischemia with no major blockages, are really similar at this time to the treatment as you would someone who has coronary artery disease. There's no strong randomized clinical trials to guide this, but what we do know is that there's a huge focus on lifestyle modification, so weight management, smoking cessation, and then we try to aggressively control other risk factors as we would, so control the blood pressure, the cholesterol levels if they have diabetes. And then finally, depending on the etiology of what their INOCA is, whether it's microvascular versus vasospastic angina, we will then treat the symptoms with different medications. And so if we can go back to the case study, you can see here that after 3 months, the patient returns for follow-up, and she had improved symptoms, but occasionally she would still get these debilitating, crushing chest pain. And on some occasions, she actually had to present to the emergency department, and then she would be told she wouldn't have any heart attack and then get sent home, and she would do this off and on again. And so in discussion with the patient, we decided to proceed with that invasive coronary function testing in the cath lab. You can see here that these are pictures of coronary angiograms that I'm about to show you. And what they do again is like using the X-ray, they inject a contrast dye in different levels of acetylcholine medications to see if we can elicit the cause of that chest pain. So at baseline, you can see here that our arteries are relatively of normal caliber. And then this is the high dose acetylcholine. As if you can remember back to that figure that I showed you, this high dose acetylcholine can lead to increased vasospasm, particularly for those who have hyperreactivity of the vascular smooth muscle bed or endothelial dependent dysfunction. And so with that high dose acetylcholine, you can see that her coronary arteries actually constrict, and she had chest pain at that time lying on the cath table. And then finally, when we give nitroglycerin, which is a relaxant, vascular smooth muscle cell relaxant agent, her coronaries return back to their normal caliber. And so in fact, this woman, interestingly, had a mixed phenotype of both microvascular dysfunction and coronary vasospasm. Okay, so I'm potentially going to leave it here. Let's see what the others, or Jeanette, or the other thoughts are. I have a few slides on MONOCA, but it's a wholly different topic. But I know we're kind of at the 140 mark, so curious to know. I can also stop here, basically, and then allow more room for questions.
So thank you very much, Dr. Luu, for that wonderful presentation. Any questions from the audience? So the drugs that you talked about to achieve anti-ischemic effects, you talked about INOCA. So what do? They reduce myocardial oxygen demand, or they what?
So both, like if it's a beta blocker, those reduce the micro-oxygen demand. Same with the calcium channel blockers. They reduce the intake of calcium into sarcolemma, reducing the cardiac demand, contractility of the heart. If it's nitroglycerin, it stimulates the vascular smooth muscle cell for dilation of the vascular bed, allowing for increased blood flow and hence oxygenation to the heart. So there are different mechanisms of that chest pain of the anti-ischemic medications.
Okay. So why for women with what's the mechanism? I think you are mostly focused on the women. So, but why women seems to be more prevalent?
Yeah, so I think it's, I mean, we are finding now that more men are having chest symptoms or INOCA. I think it's a historical, I mean, from the research, it's mostly historical. So we're finding now, so to answer your question, firstfold, we know that females and males have different hearts anatomically. Females' hearts are smaller. Their coronary arteries and vascular bed are also smaller, and the risk factors impact them differently. So they tend to have more diffuse disease and less obstructive coronary disease. And so oftentimes, like I showed, if they go for a stress testing, everything's normal, they're missed. And then the risk factors, I think, so men, you know, if they come in with classic chest pain symptoms, they're often started on really appropriate therapies, you know, at least a baby aspirin or something. But women can also have very different symptoms. And so their risk factors are often not controlled to the threshold that a male should be. And so they continue to have, you know, persistent risk factors that are uncontrolled, leading to, you know, damage of the endothelial bed. And also, I was kind of alluding to before, you know, other risk factors across a reproductive lifespan. So, you know, preeclampsia, gestational hypertension, all of that leads to endothelial dysfunction. And then, so we're seeing more and more of that in that microvasculature. So I think it's like multifactorial, leading to why you know, INOCA may be more common in women than men. Although we're seeing more and more men having it too.
Okay. Any questions? Anybody? Please just ask.
Yes, I have a question.
Yes, go ahead.
Yeah, you mentioned that menopause is a risk factor, and I was wondering if maybe hormonal therapy could help with that, because, for example, the pill has also can cause heart problems. So is there like a solution for that, or it's just a cycle of problems?
Yeah, that's an excellent question. And for anybody, if you don't, you can just enter your questions into the chat box as well, so you don't have to feel like shy to ask your question out loud. Yeah, so earlier menopause, we know, so there's different degrees of early menopause. It's a whole talk on its own. So, you know, before the age of 45, before the age of 50, premature versus early. But it's really what we're finding is that estrogen withdrawal. And so the longer you have that estrogen withdrawal, we're finding that you have increased fat deposition, like, so we call it visceral adipose tissue, so fat deposition around your organs, leading to not only a chronic state of inflammation, but also accelerated aging of the heart. And we're finding that women who have earlier menopause have, you know, increased heart muscle, you know, decreased relaxation of the heart, and also, like, you know, increase like structural changes in the heart as a result of this accelerated aging. They have shown studies in the past. They did randomized clinical trials to give estrogen back to the woman, and in fact there were some signal for reduction in heart events if you're able to intervene early enough. So within the first I would say first 5 years of postmenopause, if you give the estrogen, they did show an improvement in heart symptoms, in heart outcomes. But really beyond that, if you wait too long, the changes in the estrogen withdrawal is already taking place, and the role of estrogen therapy and that is much more controversial. And as you know, increased estrogen can lead to pro-clotting, pulmonary embolism, cancer, etc. So really, beyond 10 years post-menopause, the role of hormone therapy is very limited, and it's really at this time only given for people who have like severe osteoporosis, or who have really, that's only the real, or have significant symptoms. But and then the other thing is, if you're a woman in your 30s or 20s or 40s, let's say, and you get surgical bilateral oophorectomy, so not just a hysterectomy where your uterus is taken out, but you get your ovaries taken out due to cancer, let's say, or other causes, you actually need to be on systemic hormone estrogen to cover that period of time until you're 50, because that's also a reason. If you're not on hormone therapy, then you are accelerating your aging. So a lot of women who unfortunately have their ovaries taken out in their 40s or 50s, sorry, in their 30s, 40s, in 30s and 40s, aren't being properly managed. And so that's also leads to accelerated aging of the heart too. So to answer your question, if you're not put on estrogen therapy, what you can do, and what I do in my practice, is I aggressively control all their risk factors. I, focus on weight. I aggressively control their lipids, like their cholesterol, bring that blood pressure down, and I just monitor them a bit more closely.
Thank you.
Great.
Any other questions? So you showed an example of a woman with signs of INOCA. How do you exclude non-ischemic causes in this case? I didn't follow. I think you did talk about it.
Yeah, so a lot of it is on history. So, different potential mechanisms like autoimmune disease, lupus, valvular disease, all of that can be quite sufficiently ruled out with, an ultrasound of the heart to look at the valves of the heart. On history, if they told you that they have lupus or significant thyroid disease, the coronary angiogram or CT coronary angiogram can let you know if there's like congenital conditions that are leading to ischemia. Once I rule out all of that, and all the testing comes back normal, and I have a strong suspicion that this is likely small vessel disease, that's when I start treating as if it's microvascular dysfunction.
Okay. Any other questions?
Great.
One, sorry.
Yeah, totally.
Yeah, the wonderful talk. I was just wondering on the diagnosis for INOCA, you mentioned before that 46% using the common modalities are positive, and you get maybe 57%, you mentioned specifically for the specificity. So has that improved now of late, given these circumstances?
So the routine diagnostic imaging are still the same. It's like often quite missed. If you proceed with like the stress cardiac MRI or other stress modalities like PET, and you actually look at the coronary flow reserve, and what that does is giving that pharmacological stress agent. If you see a blunted response of the coronary flow reserve, with the increased augmentation of flow from the pharmacological agent, then it's more specific and sensitive for microvascular dysfunction, although not perfect. This is an ongoing area of research, both for myself and our entire lab in the cardiac MRI, is to, develop a sequence or technique method that can appropriately diagnose patients with INOCA. And so it's not just going to be about the coronary flow reserve or stress agents, but really I think it's looking at the integrity and the health of the vasculature itself. And this is a huge, basically what my PhD was on, and what my ongoing research endeavors will be. But yeah, stay tuned. We are always recruiting patients, men and women, for these advanced MRI techniques that we're using to diagnose INOCA. I think the future will be the next 5 years that this testing modality will be available in the clinical, routine clinical setting.
Thank you.
Any other questions? So if there are no more questions, I would like to thank Dr. Luu for that wonderful presentation. And thank you for educating us about something that is important to all of us. Thank you very much.
Yes, thank you so much. I just want to take, the final takeaway is like, everybody has a woman, important woman in their lives, their wives, your daughters, your grandma, your aunts. And so the key is just to be advocates for them. And so if they have persistent abnormalities, chest pain, they're telling you something is wrong. And if the doctors keep saying it's okay, we've done all the testing, I think it's important that you keep advocating for them and to find the right avenue, because heart disease is now the #1 killer of women worldwide. And so it's just about, telling them that you need to do more testing, you need to treat them. My clinic is now open at the Glen and at McGill. And so feel free, if you guys have any questions, to just send them to my way by email or whatever. But yeah, I'm happy to help out in any way I can. Thanks, everyone.
Thank you very much.
Sure.
Have your day. Bye.
Bye.